rather in 2 weeks' time, we are going to follow a predetermined schedule for our sessions, and the topics are have been suggested to me, and I am yet to finalize them as to how we'll keep them rolling every week. I would suggest that those who join us online, they may also suggest topics of interest, uh, and we can incorporate and include them in the list that we are in the stages of finalization. You see, there are, I would once again want to emphasize the importance of uh, going through the theoretical aspects and also the practical aspects of the subject, uh, in the sense that the objective should not be only to pass the examination. Passing examination does not necessarily make you a good specialist. You need to develop interest in the subject that you have chosen to specialize in. And as the saying goes, that if you love the work that you do, then you don't have to work, because you love doing it, you enjoy practicing it, and therefore it is not a kind of labor, or it is not something of a burden for you to carry out. I can assure you that I have put in a lot of hard work, but I have thoroughly enjoyed my involvement in women's healthcare and in the practice of this specialty right from day one. And not for a single day have I ever regretted why did I join it. And whenever I read something new, I am made aware of the lack of knowledge that I have. Not how much I know, but how much I do not know actually. And therefore, I would want you, this is too strong a term or too, but to immerse yourself in the subject and read it and study it for the purposes of knowing it, not just passing the examination. That is one of the most trivial, most basic needs for you to be in the subject. Last time, there was a presentation by Dr. Mavish, one of our residents, about this carcinoma of the cervix. And we went through that, but many of our other residents here had not studied it or had not read it, and I asked them to read it and submit their assignments about carcinoma of the cervix, and I was then asked to discuss carcinoma of the cervix in today's session. Since I was told only yesterday, I didn't have the time to prepare a PowerPoint presentation, so I would be discussing it verbally, and maybe in some places I will, if I have, because I tried to make a PowerPoint presentation, but it was not really possible to do that in just one day or in a few hours, that I would complete a PowerPoint presentation on carcinoma of the cervix. But I would begin with this, that out of whole of gynecology, if there is one particular topic which is intriguing, which is the hallmark of many aspects of understanding of the subject, and which probably has one of the important impacts on the understanding of the disease process and how the disease can be diagnosed early, and how it can be even prevented, then carcinoma of the cervix is a prime example of that. It was in late 40s that Papanikolaou, and this all happened because this part of the female pelvic anatomy is within the body, but it is also exposed and it is accessible without a surgical intervention. And therefore, the issues, the problems, the diseases which it is involved with can be diagnosed on examination and also by other means without the opening of the peritoneal cavity or without major surgery. And then it is also uh, was subject to external influences in a manner that caused disease. And when I was studying for my examination and for better part of my professional involvement in OBG, there were various theories how carcinoma of the cervix develops, what causes it. And the most common in the 80s used to be that it was the smegma, that substance which collects within the prepuce of penis, and it was considered that smegma somehow brought about changes in the cervical epithelium, and that caused cancer of the cervix. In addition to that, there were all kinds of hormonal influence about smoking, about low social status, about early age of, that was recognized, early age of coitus, multiple partners, sexual promiscuity, etc., etc. And multiparity. Of course, multiparity meant was translated into terms of excessive and more frequent intercourse. So those were the speculative aspects of causation of uh, carcinoma of the cervix. And it was also at that time considered that it was less common in Muslims and Jews than in other race or than in other religious or beliefs. And the understanding was that perhaps it is the circumcision of males that prevented or that caused less incidence of carcinoma of the cervix in Muslim women. It revolved around that till it was discovered that actually more than 90% of carcinoma of the cervix is caused by human papillomavirus infections. And now more than 100, nearly 200 varieties of human papillomavirus have been identified. And amongst them, there are two varieties, speaking from the point of view of carcinoma of the cervix. One are the high risk, the other are less risky, which cause carcinoma of the cervix from that point of view. And the others are which cause the warts, vulval warts or vaginal or cervical warts. So they are responsible for that, not the malignant aspect. जी ये उन्होंने हाथ खड़ा किया, क्या सवाल है जी? You want to ask some question, Zohab Sheikh? आवाज तो नहीं आ रही? Please write down the question if you have or a comment that you want to make. Now, I just referred to the availability of the cervix for examination for the purposes of early diagnosis and screening, etc., or prevention also. So if you know the etiology or if you know the causation, then of course you can devise and practice measures which will reduce the chance of infection, which will reduce the chance of development of the disease. But it all started in late 40s when Papanikolaou, he thought of that the epithelium from all surfaces, epithelium is shed off. And so would be the epithelium of the cervix. And it had been at that time recognized that carcinoma of the cervix predominantly was squamous cell carcinoma. And we all know that there is a change of epithelium of the cervix from endocervix to the ectocervix, because ectocervix is lined by squamous epithelium, which is the lining epithelium of the vaginal wall. And then there is a sudden change in that area at the level of the external os, and the endocervix is lined by columnar epithelium. So that was known to be squamocolumnar junction. But overwhelmingly, carcinoma of the cervix uh, happens to be squamous cell carcinoma, which meant that it is a disease of the ectocervix, and only about 5% carcinomas are adenocarcinomas which develop from columnar epithelium. And therefore, the uh, endocervical contribution to the incidence of carcinoma cervix was very small. And he obviously thought, which now appears to be something which should be quite obvious, that you collect cells from there and assess them and see, are there any changes, those pre-malignant changes or those changes which can be identified as sinister or as ominous, and then that these are the changes which probably ultimately develop into frank carcinoma, and that is how it all developed. And since the cells can be collected from the squamocolumnar junction, as well as since they are shed into the vagina, they tend to accumulate in the posterior fornix. And if you took secretions from the posterior fornix and examined those cells and did their cytological examination, then a trained cytologist or a pathologist will be able to identify those early changes, which would mean that there is something going on. And also, if there is a frank change into cancerous form, then that obviously would be diagnosed quite early on. Since radical operations for carcinoma of cervix had been developed much before that, Wertheim's hysterectomy, I should know, but I don't know at this point. When was Wertheim's hysterectomy first practiced? Wertheim was an Austrian gynecologist. Note करें Wertheim hysterectomy, and so much so, this is great credit to the skill of those surgeons, that a radical hysterectomy surgical procedure was devised by a gynecologist by the name of Shota, Schauta. Shota's operation is radical hysterectomy carried out vaginally, and that was done. And this was done all before Papanikolaou smear was introduced. Anyway, so carcinoma of the cervix and its significance and its impact on women and its being very common, etc., that was known already. But Papanikolaou's intervention or description of early diagnosis and screening, that is totally a new concept. And therefore, you see, the concept of screening for cancers, that started from carcinoma of the cervix. And that's why I said that carcinoma of the cervix is a very intriguing disease, in the sense that it gives you insight into so many aspects of the disease processes within the human body, that it can be a model for many other areas. That you identify the early changes, and you can do that. And now there are other methods of not only collecting cells from there, from carrying out certain tests, and then the development of the colposcope, by which you examine it more clearly, and you can almost see, I wouldn't say exactly, but almost see histological changes in situ. That you find that there are those changes which are pathognomonic of the disease process, and therefore they help you identify where you to take the biopsy from to confirm the diagnosis. The second point was, of course, that if you diagnose it early, then there can be ways and means by which you can also assess the extent of the disease process, up to what extent it is gone. Now, we all know that in cancers, we stage the disease. It's early disease because the cancer tends to spread locally as well as distally. Local extension is by local uh, proliferation of the disease, and distant metastases are through, of course, blood vessels and lymphatics. So therefore, this is what happens. But if you diagnose it early on, before it has had the time to spread locally or even distally, then comparatively limited interventions could prevent the spread of disease or its development into more advanced degrees. So that was these are the lessons to be learned from the development of screening processes in the cancers, and which can be applied to other areas and to other disease processes as well. You see, like ultrasound was introduced by an obstetrician thinking that sonar is, as I asked you last time, I'm sure that you would have, sonar is sound navigation and ranging. That if you apply, because that was invented to identify German U-boats or submarines in First World War, and Ian Donald then applied that principle, thinking that the fetus is in a fluid environment, and therefore we could measure, or we could examine fetus to some extent through the sonar, and from that ultrasound and all that developed. And now ultrasound's application is more or less everywhere, that wherever, in places sometimes when there is not even a fluid environment or through which you go. For example, you would see an anesthetist here looking for nerves within the arms, etc. So that's how the application of various modalities and various techniques takes root. Now, another trend which took place rather recently is prevention of the disease, prevention of the cancer. It is not by diet or in anything, by the since the knowledge came about of the role of human papilloma virus in the development of cancer, that 90% of it is, or more than 90% it is because of HPV infection. So if you could give vaccine for that and prevent the infection. Now, it is also known, you have a, and then out of those high risk varieties, there are two varieties which are responsible for 71% of carcinomas. Those are HPV 16 and 18, and HPV 31, 33, 45, 52, 58. अच्छी बात है, अगर आप ये सारा याद, they are responsible for 19%, so that makes it 90%. So 90% are because of these 5 and 2, 7 varieties. And therefore, in early part of this century, 2 vaccines came in. One was Cervical, which was effective against 16 and 18, and the other was Gardasil. Gardasil was effective for 16 and 18, and in addition for 6 and 11. 6 and 11 are the ones which are which cause warts. And now that nanovalent HPV-9 is available, which is for these 7 high risk and 2, 6 and 11 non-carcinogenic varieties. So that is there. And then it was also known that these are a couple of other factors, that nearly 90% of the infections are not detectable within the first 2 years when they happen. And women are exposed to this infection as soon as they have sexual intercourse. And as it is said that early on, the infection is only transitory, and it passes off on its own and persists only in a very small percentage of cases. So although there is almost universal exposure of women to HPV as soon as they start sexual activity, but the infection persists only in a comparatively smaller number, and even further smaller number get to have that change into carcinogenicity. And there are different points whether it remains I mean, it's clear or it remains latent in the basal cells. Only 1/10 of all infections become persistent, and these women could develop cervical precancerous lesions. Now, overall incidence of the C cervix. This is considered to be one of the most common cancers amongst females. It is the fourth most common after breast, colorectal, and lung cancer. And in 2012, it was estimated that there were more than 500,000 cases of new cases of cervical cancer worldwide. And there were more than 250,000 deaths from that. If there are 527,000 cases, new cases, 265,000. This is a little over 250,000 deaths from cervical cancer. So that is, and then there are terms at LMIC, low and middle income countries. That it is more common in lower and middle income countries. The reason, of course, is quite obvious. That in the developed countries, there are well-developed screening programs, so there is early detection, early taking care of that, and now on top of that has come in the vaccine, and now it is kind of mandatory for all girls and now even boys, because boys and men are the people who would be transmitting the infection to the women. So now it is universally, the vaccine is given to boys and girls. Two of my grandchildren, one is 16 and the other is 13. 13 is a boy and 16 is a girl. They have already been given, they are in Canada, and they have been given this vaccine in school at that age. So 9 to 14 years is considered to be the primary time, because at that time, early on infection and exposure to infection is also considered to be even a greater part of, or a greater age for greater vulnerability at that age, because the tissues are still developing and they are going through that process. And in the developing countries, it is the second most common cancer in incidence amongst women. Fourth common globally, second most common in low and middle income countries, and third most common in terms of mortality. And majority of new cases, 85% overall, globally, 85% of cases and 90% of mortality now occurs only in low, middle, or low social classes. So because of low resources, because of low socioeconomic and weaker sections of the society. So far as prevention is concerned, there are two aspects. One is primary prevention, and the other is secondary prevention. Can anyone comment about what would be the primary prevention and what would be the secondary prevention? मैंने अभी तक जो कहा उसमें दोनों चीजें
वैक्सीन जो आपने बताई that will be the primary.
कौन सी?
Vaccines are जो
Yes, vaccine is the primary prevention. So it would not allow HPV, those varieties, to take hold and start the infection. And the secondary obviously is then that if that occurs, that is through screening और वो फिर आप उसके साथ वो करोगे. So prophylactic HPV vaccination as a preventive strategy should target women before initiation of sexual activity, focusing on girls aged 10 to 14 years. And important is all the vaccines are recombinant vaccines composed of virus-like particles, VLPs unko bolte hain, and are not infectious. For girls and boys aged 9 and 14, a 2-dose schedule, 0.5 milliliters at 0. The first dose is whenever it is given, and the second dose is given after 5 to 13 months. 5 to 13 months. और अगर उससे पहले दे दी जाए सेकंड डोज तो फिर एक तीसरी डोज भी देने की जरूरत होगी. वो 016 होती थी पहले इस तरह से. सो यू कैन से दैट 2 डोजेस 0 and then after 5 months or 6 months, or if it is given early 016. So ये है. And now in the United States of America, no other vaccine is available except for nanovalent, which means the 9-valent, and we should also try to get that. And अगर हो सके तो ये है. Now it's a whole separate subject of what kind of women or at what age should it be given, like 9 to 14 is that is the ideal, but if someone has missed that, then then there is that catch-up age. So assignment for you is look up at that when can HPV vaccine given in those who are say married at the age of 26, or can a woman at 36 years of age who has got 2 children, can she have a vaccine, and would it be beneficial for that? And what about a woman who is 45 years of age or postmenopausal? So there are these 3. Ideally, it should be given as prophylactically 9 to 14 or 15 years. But what about a woman in her 20s, mid-20s, mid-30s, and mid-40s? The reasons why should it be given, or why should it not be given? Now, secondary prevention is through screening. The next question for all of you is obviously to explore and to then read about is cervical screening. What are various modalities of cervical screening? One is pap smear. The other is मैं विष्णु से बताया था, एक है VIA, visual inspection after acetic acid. So लिखो आप, what is the significance of VIA? Where would it be applicable? What concentration of acetic acid is used? What is its mechanism? What does it show? What is its sensitivity and specificity? That also brings me to the question that I gave you last time, that you have to look up what is meant by specificity and sensitivity and specificity. And the third test is, and what is the practical importance for a test like VIA in countries like ours? Advantages, disadvantages, etc. Vis-a-vis, you can have 3 columns. One is cervical screening, as we know, by smear, cervical smear. Nowadays, it is better to call it cervical smear than pap smear. Pap smear had the 2 components of cervical and posterior fornix, and cervical smear is only taking the scraping of the cervix. The second column should visual inspection after acetic acid, and third is Lugol's iodine, Schiller's test. What does it show? And what is the composition of Lugol's iodine? The gynecology book that I read for my FCPS that even gave the percentage of Lugol's iodine, how much is the potassium iodide and how much is the iodine, etc., and how do you prepare that, and what is its significance, how do you apply it, etc., etc. So Lugol iodine and their comparison, their sensitivity, specificity, what are the advantages, disadvantages, how far would they go in. Now, the objective of the screening tests is to identify something going wrong or something not being good, something not correct or right. There's something is wrong, and then they may also suggest from where to take a biopsy for the confirmation of the diagnosis, or in which cases to go for colposcopy. And fourth, of course, is colposcopy for further evaluation to help you take a diagnosis. Ultimate final diagnosis of carcinoma of the cervix is through histopathology. And in early diseases, next question is, what are various methodologies of cervical biopsy? It can be a punch biopsy. It can be a cone biopsy. It can be a leaf. And a relevant question would be that what is the significance of visual inspection after acetic acid in low middle income countries like Pakistan? You see, now coming to the end of my career or nearing that, when I reflect back, that there are so many things that I would say that I should have done like that. I would have within the specialty, and I could have done that. I could have done this, etc., etc. One of the regrets is that I could not initiate a program of cervical screening in my department. We did start, but not enthusiastically, not to the extent that it really got established. And therefore, wherever we work, I think it is our responsibility individually as specialists in this specialty that we initiate, we educate public, we start this. This is something which I haven't even started or on a regular basis, even in my private practice. Although this is something which is desirable, and one should educate women who come to you in OPD. You could give a brochure for that, that this is, or give a session about that. And also at the time of examination, when they come for gynecological examinations, take a smear. Or even in pregnancy. During pregnancy, if you take smear, then there are certain things which may kind of mimic that there are those early changes, but they have to be then taken with a pinch of salt, is in the sense that they have to be further explored and assessed. But those are the occasions when women are coming to the health facility, and which afford us the opportunity to take samples for smear, and then at least screen that population which is coming to the hospitals. Now, after this comes the staging. Staging is important. Like all cancers, cancer of the cervix is divided into stage 1, 2, 3, 4. One is when it is generally speaking for all cancers, one is when it is limited to the organ. Second is when there is minimal spread. Third is when it is spread locally to a greater extent. And fourth is when it is spread distally or has a distant spread. Now, in most of the cancers in gynecology, we look towards FIGO's classification, International Federation of Obstetrics and Gynecology. And FIGO has a cancer committee which meets regularly and which looks over things. And they publish their reports. One report came in, I think, 2012, but the last report was in 2018. And that has given these for individual cancers, and these reports were published in International Journal of Obstetrics and Gynecology, which is FIGO's journal. Most of its articles are to be purchased and are not available freely, but this FIGO's classification and description of these cancers of various reproductive organ structures are available free on online, and I would urge you all to make to look for that and collect all those in your laptops or computers or tablets, wherever you put them. Since the staging is from 2018, FIGO staging has changed a little bit. Not a little bit, but significantly, in the sense that previously we depended only on physical examination of the patient to stage the disease. And we used to do an EUA and cervical. That was the standard term, EUA cervical, EUA staging and cervical biopsy. Now, EUA, examination under anesthesia, and along with that, of course, in selected cases or where you thought that the disease was more advanced and had spread out, then we used to also have cystoscopy or sigmoidoscopy. But mostly it was that on this you inspected the cervix, whether there was a growth apparently on the ectocervix or not, and then when you did digital examination, that was what told you about the involvement of the parametrium particularly. Parametrium, that whether there was any thickening in the lateral fornices, and if there is a thickening to the lateral fornices, what is the extent, up to what, how much distance from the pelvic wall has it spread, or is it spread to the lateral pelvic wall so that there is no free tumor-free space between the cervix and the lateral pelvic wall, because that accounted for a further stage. Whereas if there is some spread to the lateral some spread laterally, that would be stage 2A, stage 2A, and if it is spread up to the pelvic wall, that is the stage, of course, becomes different. Now, in addition to that, FIGO in 2018 have also incorporated oncology committee to allow imaging and pathological findings where available to assign the stage. Imaging. And that imaging can be through CT scan, MRI, PET scan, or even ultrasound in experienced hands. So all kinds of imaging. And pathological, now you see that there is a thickening, or you identify that there is a node which is visible. You take a biopsy or you aspirate that node and see what the results are. But in those areas or those countries where tuberculosis and other such diseases are common, the nodes may be enlarged because of those diseases, and therefore it becomes imperative that you take a biopsy or aspiration of the node from that. So the FIGO staging was based mainly previously on clinical examination, with the addition of certain procedures that were allowed by FIGO to change the stages, like cystoscopy and sigmoidoscopy. In 2018, this has been revised by the FIGO Gynecologic Oncology Committee to allow imaging and pathological findings where available to assign the stage. Or a diagnosis of stage 1A1 and 1A2 is made on microscopic examination of loop electrocyte or cone biopsy specimen, which includes the entire lesion. It can also be made on a trachelectomy or hysterectomy specimen. Now, you see, if 1A, it depends upon the extent in terms of centimeters, how far it is, how deep it is on a specimen of cone biopsy, and I would advise you to go through that. So that's about staging. Then the management of the disease in terms of invasive disease or pathological staging, we have to see वो ट्यूमर नोड वाली भी होती है, ट्यूमर और नोड वाली. And then histological classification, like most of them are squamous cell carcinomas and adenocarcinoma, and then there is, and then grading is dependent upon its differentiation of the cells. So if it is well differentiated, it is grade 1, and it is if poorly differentiated, grade 3, and moderately, that's 2, and then grade X is ये है. मैं अभी आज तो मेरा ख्याल है इतना ही करता हूँ, इस वक्त तक इतना ही रखते हैं. If there are any questions, because we can talk about the management of surgery, radiotherapy, chemotherapy, and there are important points. Early stage cervical conization, total simple hysterectomy, or radical hysterectomy. There are 3 kinds of surgeries which can treat for treatment of cancer of the cervix: conization, simple hysterectomy. But don't say simple hysterectomy. For invasive cancer, generally it is radical hysterectomy, which I refer to as Wartime hysterectomy. And you should know what are the various not steps, but what structures are really required to be explored and removed, and to what extent that surgery is to be carried out. तो वो Wartime hysterectomy या radical hysterectomy का करोगे. इसमें इन्होंने इस में ये दिया हुआ है टाइप्स ऑफ रेडिकल हिस्टेरेक्टमी: सिंपल, एक्स्ट्राफेशियल, मॉडिफाइड रेडिकल एंड रेडिकल हिस्टेरेक्टमी. और उनमें कि क्या क्या चीजें जो हैं उनको निकाला जाता है. इस आर्टिकल देखा आर्टिकल दिस इज इम्पोर्टेंट. ये मैंने पिछली दफा दिया था तुम लोगों को, नहीं तुम लोगों ने खुद ही देखा था. गुड. सो ये है. और इसमें दिस इज अ गुड आर्टिकल बिकॉज इट शोज कि स्टेज 1B2 और स्टेज 2A1 जो है उसमें किस तरह का करना है, वेरियस स्टेजेस दैट. और फिर मैंने एडजुवेंट और न्यू एडजुवेंट का भी बोला था, वो भी आपने देख लिया. व्हाट इज एडजुवेंट थेरेपी?
आफ्टर ट्रीटमेंट जो देते हैं वो एडजुवेंट है.
So chemotherapy or radiotherapy which is given after surgical intervention is known as adjuvant. Adjuvant radiotherapy, adjuvant chemotherapy. And that which is given before surgery is known as neoadjuvant. तो मैंने इसमें कुछ हाईलाइट किए हुए हैं, लेकिन आपने पढ़ा है तो बड़ा अच्छा है.
नेक्स्ट क्लास में आपके साथ भी डिस्कस कर सकते हैं इसके बारे में.
हाँ हाँ.
मैनेजमेंट की आपकी प्रेजेंटेशन थी.
ठीक है जी. मैं अगर जो लोग हैं जिन्होंने हमें ज्वाइन किया हुआ, I'd like to have their comments on the various aspects. इसमें मैनेजमेंट का इम्पोर्टेंट है. You all need to make a summary of that you come across a patient in OPD. What are the and you diagnose it to be cancer of the cervix stage 1A2. So what would be the or stage 2A? I am naming these stages in which surgery is possible or surgery would be indicated. So what would be your advice to the patient? This is what you know what is written in this chapter, but you come across in a public sector hospital a patient, or even in a private clinic you come across a patient who has got stage 2A or stage 1 disease, and what treatment would you advise? 1. Treatment of stage 2B and onwards is obviously quite simple, that you would send the patient for radio chemotherapy to an oncology facility that you would do. And what would be the treatment after someone who has had treatment and has a relapse? All these are given in this. Relapse का treatment का वो तुम्हारे पास 2-3 फिक्रे होने चाहिए कि किस किस्म. And what is the palliative treatment? Terminally ill patient, terminal stages, palliative treatment, and counseling of that patient. Counseling में C नहीं होता, इस counseling में S होता है. how would you counsel that patient? यूसुफ साहब भी आ गए हैं। अस्सलाम वालेकुम। आवाज नहीं आ रही इसलिए मैं हाथ हिला देता हूँ।
अस्सलाम वालेकुम सर।
क्वेश्चन किसी ने किया नहीं है तो फिर हम